Okay, now, so that leads me to the next question. So you've done the biomarker tests, and the recommendations, of course, are the next step would be if it's warranted to do an in-office liver scan of some type, and there's different options depending on what country and what's approved and stuff. How realistic and how accessible is it for clinics in both your specialty areas to get I'll just pick FibroScan. I know there's others that are out there as well, but to pick a scan like that to have done. Actually,
Well,
FibroScan was called out in the document specifically, right? So
yes. I think if I did the test, if FIB4 is less than 1.3, then I really do not do a secondary screening. If the FIB4 is greater than 1.3, then I will proceed to do a FibroScan. Unfortunately, I do have FibroScan available in my office, but I think generally primary care doctor does not have FibroScan in their office. And to order a FibroScan in Canada, it's not covered, and people are actually reluctant to dish out that funds to do that. But if there is a FIB4 that's over 1.3, and if we can tell patient, look, we think that you have fibrosis, and we need to see how bad in your liver cirrhosis, most people will be willing to do the FIB4. In Toronto, we're lucky because we do have readily accessible elastography or FibroScan machine. But I think it's not something in some communities in terms of availability of the secondary screening.
Yeah, I want to hear Ken's comment too. I will. You said something really important about accessibility, and it is an issue because not only do we have the concerns about eating and lifestyle and accessibility for that, but on even assessing liver disease, if people are in more remote areas, they're at a disadvantage, right?
Yeah, so let me clarify
Yeah.
this, because this is a thing we discussed across the different groups that put these guidelines together. So the FIB4 is a test that was chosen because it should be widely available now across the world. I know that not everybody measures AST or ALT, but the ADA at least recommends once a year to have them for people with diabetes, same as a CBC. So eventually you have this information in settings that you have CBCs and liver function tests. Just to give our audience a sense of how often they would have somebody with diabetes and a value above 1.3 would be, if you took 100 people with diabetes, about 60 would have a value below 1.3. 10 would have a value double that number, greater than 2.6. These people are at the highest risk of having advanced fibrosis, and I think most would have it. Then you have this gray zone between greater than 1.3 and 2.6. That'll be about 30% of the people. These are the ones who get the greatest benefit from a second test. Now, we don't have a FibroScan in our endocrine clinic. I do it for my research, but you don't need to have it. We just order the elastography test. So the FibroScan gives you an idea of fat in the liver and fibrosis. Fibrosis is what we're looking for. We're not looking for fat because we already know that about 70% of people with obesity and metabolic risk factors or diabetes has fat. So we're starting from the point that probably most have fat. We're looking for how that fat, particularly steatohepatitis, the inflammation induced by that fat, is triggering liver scarring, fibrosis, okay? So in short, I can say that we just order the test the same way we order an X-ray, and our liver doctors already have it, and it's nothing that we have to have today. If we have it by the next visit, that is fine. Now, where do commercial biomarkers come into for those who cannot access, again, an elastography test? And there are other imaging tests like shear wave elastography, for example, that can be measured. The ELF test has been chosen because across the world, it has had the greatest evidence as a second test. Again, none of these tests are perfect. And I just have to say that the FIB4 has not been very well validated in youngsters, or particularly below age 35, because the equation doesn't give you a high number, and above age 65, you probably want to use a higher cutoff of 2 to identify people. And again, final thought, I'm sorry I'm talking a lot, but
Great.
the FIB-4 is a test with high specificity. What does that mean? It probably does. If it's high, you probably have a problem. Now, if it's below 1.3, it doesn't mean that you can have a problem. Actually, we know that it will miss some people with moderate fibrosis, but the test is more than anything trying to take care of those who most certainly have a problem. And eventually, we don't know how often to repeat it, probably once every other year or once a year. That's to be determined. But it's the easiest, cheapest way to begin knowing who to refer to the hepatologist.
Ming, you're going to say something before? You know, Ken too. There were a couple talks this week at a conference I went to too about lean NASH. So it's not just the obese. There still are, you know, roughly 10%, right, that are still going to be lean. So I guess there has to be other indicators of that, because we don't want them to
Absolutely.
be
So again, we didn't mention the other high risk group.
Yeah.
So AACE divided the American Association of Clinical Endocrinologists in 2022 had 3 high risk groups. A, people with diabetes or pre-diabetes, particularly if there's obesity. B, obesity with findings of metabolic syndrome. And C, were people who already have elevated liver enzymes, or those who already have steatosis that people don't do anything. If you find somebody with an incidental finding of fat, now they become a high risk group to look into this. And I have to say, just for some simple things I've learned, a normal ALT is below 30. Actually, in women, epidemiological studies have shown that it's 19, and in men about 30. When it begins getting above 30, studies have shown that you have more morbidity, liver morbidity, and higher mortality, whether it's NAFLD or other causes of liver disease. So if you have an ALT above 30, I would say almost always they have fat in the liver. And if the AST is higher than 30, particularly if it's above 35, you most likely have fibrosis. So remember those numbers. Same as if your platelets are in the 150 and below, it's likely you have portal hypertension because the spleen captures the platelets, and you have advanced fibrosis. So little tips for the practitioner.
Those are always.
I like to add, Mike, I like to add for the lean NAFLD patients. I think the thing, if there is family history of fatty liver and liver cirrhosis, even if the patient has normal BMI, I think these group need to be screened as well for fatty liver, especially if they're having fatty liver.
Thank you. Oh.
Yes, that's a very important. The AACE guidelines, getting back to the AACE guidelines, show or recommend, in addition to the ones that we already identify in AACE, people with a family history of cirrhosis from NASH, and people with more than minimal alcohol intake. You have, again, gets into this gray zone of NAFLD or alcoholic liver disease. But the Canadian guidelines recently recommended that any alcohol intake could be harmful. And definitely those who drink in moderate amounts are at higher risk of liver disease. So alcohol intake is a big risk factor. And again, the Canadian new guidelines say any kind of alcohol intake could be potentially harmful, particularly if you have steatohepatitis and you don't know it. So that's why it's so important to stratify people.
I wanted to talk a little bit about you mentioned the cirrhosis side of it, and it's true that patients who are unaware can actually jump into the cirrhosis category without even knowing. I saw some data that said it's something like 70% of the people in a study from Australia it was incidental. It wasn't something that they were actually looking for, and they found cirrhosis already. So the early assessment and the whole reason why we're doing all of this testing is to try to get people assessed and treated way before it's too late, right?
Right, and especially it's gratifying to be able to reverse the liver scarring, reverse the fibrosis, and other comorbidities of fatty liver patients.
And as you say, another reason why to do the FIB4, because if you have a FIB4 that, and then your workup it suggests you have moderate fibrosis, what we call F2, you should abstain from alcohol use completely, the AACE guidelines say, because it's a cofactor for progressing to cirrhosis. So another caveat is that it tells you what your risk to alcohol is. And second, it also tells you that if you have diabetes, you probably can use some diabetes medications like GLP-1 receptor agonists or pioglitazone, or if you're obese, which either drug works, but you would like to focus on GLP-1s that are approved for obesity, to use this. And a third benefit is that if you have fatty liver with fibrosis, you probably should be also using a statin because it reduces your high risk of cardiovascular disease. So there are a number of secondary benefits beyond the liver that are important to stratify. So actually, there are recent studies that show that FIB4 predicts also your risk of cardiovascular disease. The higher the FIB4, the higher cardiovascular risk. If you have, again, fibrosis, again, you should get an hemoglobin A1C in your patients because diabetes and prediabetes are so common. So there's a number of ramifications that involve the liver, of course, and the cardiometabolic health of your patients.
And to diagnose fatty liver disease patients also important in terms of cancer screening and cancer prevention, because we know that NAFLD patient has increased the cancer, not just liver cancer, but other cancer as well. To be able to identify the patients, stratify them, it helps us also to do age-appropriate screening as well for cancer prevention.